I'm Lizzie, this is Liz. There's been a little bit of presenter confusion this week, so there's the slides like lack information or anything, they're quite basic, but hopefully it should be just a run through of all the sort of explaining counselling stations, the more tricky ones anyway, that colleagues have had in the past on their OSCEs. So it's based on scenarios that have been and that I'm sure will come up again, so hopefully it will be quite relevant to what I'm saying. So those two slides are just going through some of the past OSCE stations. So there's been lots and lots and lots of counselling stations, but just practice them at least once each, and then at least you'll have a bit of an idea about what's going on. And they're all on Ask Dr. Clark, and what we did was just run through them all, which meant that by the time that OSCE Day came, there was one station that we hadn't practiced. It was nice just going in and knowing that you could nail the station, and it was made it a lot less stressful than it could have been. So basics just about counselling stations in general. Most of the stations in the OSCE at Leeds, they were kind of like 3 phases. So they started with a history and a review, just a general patient history, and then you'd get some investigations that you had to review that would lead you to some sort of conclusion, and then you'd have to counsel on the results or counsel on sort of the findings. Because of that, you need to be quite concise, so it's good to have a formula and have sort of a set spiel to make yourself look slick, because that was what will set you apart.
And really good timekeeping, because sometimes they don't stop you. So if you spend 12 minutes on a history, that's on you, and you've missed the other half of the station.
And sometimes it does seem really disjointed as well. It was quite weird, wasn't it, in the actual thing, because you just have to move on, and it seems really rushed. You have to do something in 4 minutes, which you would never do in 4 minutes in real life, but they expect that, and that's what mark schemes are based on, so it's fine. So it's sort of a standard formula, which I'm sure you all know. So start off by just assessing their base level of knowledge, and sort of the level of detail that they want to know. Explain everything at their level. There's no need. It's really easy to get bogged down in a really sort of detailed explanation, because you know so much about something and you feel like they would want to know sort of it in the same level of detail to understand it. But most of the time, people are really happy with really, really basic explanations. So it's best just to do it like that. Keep it simple. Check their understanding all the way through. Make sure that you give them time to speak. Try not to just do a monologue. It's easy just to speak, especially when you're nervous. So keep checking their understanding, ask them the questions, all their sort of ideas, concerns, expectations is obviously really important, and that's what you get marked on.
And it is really easy marked for counselling if you just have the set performer for all of them. Even if a station does throw you and you feel you haven't practiced it, you have the set performer that you need to go through. You will do well at them, and just remember to ask them what they're concerned about. And that's a few points in itself.
And it's easy to neglect them as well, because if you've got a set spiel for something like explaining epilepsy or explaining asthma, even though you know exactly what it is and you feel like it'd be really easy to explain it, it's really easy to neglect it, and then you start stumbling on your words, and it's just a nice break as a station if you just have got that just ready to roll off your tongue and ready to go. So the first case, I was just going to go through it in a case-by-case format, so just going to start with sort of some of the things that we had in our OSCEs and some of the things that have been in OSCEs in the past. So the first one is one that I'm sure people are familiar with, which is newly diagnosed epilepsy. So the scenario that we got was a 20-year-old woman, and she'd recently been diagnosed with epilepsy. We just had to counsel her on answer any questions about her concerns and things. So even though everyone knows what epilepsy is, it's actually quite hard to get it in sort of a concise manner, so that you explain it in just sort of one word. That's what we tried to do for sort of every illness like that. We tried to just get something where you could just say it in one word, something that would explain it and tick that box, because then you can just move on, you can get on to something else. So epilepsy, for example, is disordered electrical activity in the brain leading to seizures. You can diagnose it after 2 seizures, and then that's that bit done. Reassuring the patient by just saying how common it is, and that it's 1 in 100 people, so it's something that, even though it will impact their life in a big way, it's a lot of people have it. And then sort of putting their mind at rest a little bit about the causes of it, so the fact that it can be due to structural abnormalities, but that's why we do the investigations like MRI and things, and commonly no cause is found, which is what the epilepsy is in this case. So
So then they asked some questions about treatment. So again, just keeping it simple, like trying to think of one line that you could just roll off the tongue and then it's done. So just the fact that it aims to control seizures, not to cure the condition. So there's 2 routes that you can go down. The old first-line treatment, so they're like valproate, carbamazepine, phenytoin, or the new second ones, so they're like Keppra, the levetiracetam, or lamotrigine. So it used to be that the first-line ones were the ones that everyone would come across really commonly, but now sort of things like Keppra are much more common. Obviously, you can sort of get out of this quite easily just by saying the neurologist will take you through what treatment will put you on. So they'll just decide which treatment best suits you, best suits your lifestyle, and they'll titrate it up so that you can get the maximum benefit with the minimum side effects. So the main issues just to be aware of, and just to sort of point out if they ask any questions, you don't really need to go any deeper into it other than some of the old ones, have problems in childbearing, and also sort of drug interactions and things because they're enzyme inducers.
So are the newer ones okay?
Huh?
Are the newer ones okay in pregnancy?
Yeah, I think there's like some that are still. The main one in pregnancy is valproate, isn't it? And phenytoin are bad in pregnancy. I think Keppra is fine in pregnancy, which is why that's lamotrigine as well.
Yeah, I think so.
Because like a lot of young women, when you see them sort of coming through hospital, a lot of young women are on Keppra now. I think just because anyone of childbearing age, like, as it's now more common, it's actually just a lot of people on it.
I think that was one of the key points for this station in particular, is actually the 20-year-old woman. So she might not actually bring up the concern about pregnancy and that she wants children. So some of the actors might, and that's really nice, but it might not help you out. So you need to be aware that she's a woman and to talk about that in the counselling as well, sort of not to just stop treatment because she wants to get pregnant, and always to seek a doctor's advice on certain things.
So as with all of things, it's important just like, if you think about stuff and try and compartmentalise it so that you've got sort of a set list of things that you've got to get through, you can just keep rolling through it and then you don't stumble on things. So obviously with epilepsy, lifestyle is really important. So it's a massive impact on people's daily life. So you need to sort of tell them all about the things, swimming, tell all their friends, make a trigger diary, importance of complying with medication. Other things might impact alcohol, so because that lowers the seizure threshold and interferes with meds, it can also sort of make the alcohol have more of an effect as well. So, I mean, obviously this is a young woman, so she's probably not going to want to stop drinking completely. So it's sort of, making sure that you come across as getting a balance with her life. So avoid binging, she can drink alcohol at, normal daily limits. So it's not sort of like, it's trying to take her life into account, basically. One of the big things with epilepsy is obviously driving. They have to inform the DVLA, and if you think that they're not going to inform them, you have to do it. You've got the legal responsibility. You can drive a car or a motorbike if you've been 1 year seizure-free, or if you've had 3 years of seizures just in your sleep. And it's important to check their employment as well, because lorry drivers or people that drive a bus, they have to be 10 years seizure-free, and it has to be off anti-epileptic drugs as well. So that's obviously, if you don't ask what they do as a job, then you could miss that. The biggest things in this case, it's been in the past, was the fact that she was a woman and that she obviously had problems with contraception, pregnancy and things, and that's what she was most concerned about. So it's just trying to show that there are options in this, how this won't interfere with her life. So some of the anti-epileptic drugs can interfere with the contraceptive pill and make it less effective, including the emergency contraceptive pill as well, so all the hormonal ones. So, you can tell her that, but also say, there are alternatives. It doesn't mean, that this is going to really impact on your life, because of the intrauterine device, the emergency coil, condoms. So it's again just, trying to offer alternatives to show how this is going to have the minimal impact on her life. Pregnancy, she wanted reassurance that she can have a healthy, normal pregnancy, and just the importance of planning it with a neurologist, because then they can sort of balance your treatment and make sure she's on the right treatment. And breastfeeding, most of the anti-epileptic drugs are only secreted in really small quantities, so breastfeeding is safe and it's encouraged in epileptic mums. Financials often forgotten as well. There's a lot of benefits that are available, sort of sick pay, work employment pay and stuff like that. And also they get free prescriptions. So it's important, I guess, just to have a brief knowledge of that, just so that if anyone asks any questions that you can mention it to them. And then obviously support, like it's always a saying support groups, GP, online resources, like just to talk about it. Any questions about that one before I move on?
I might miss this, but how long are normal counselling stations in the OSCE? Are they 12 minutes?
They're either combined, so it's kind of a 6-minute history, or like a 4-minute history, a 2-minute look at results, and then a 6-minute explain, or it's
12-minute.
8-minute.
I can't remember what ours were.
It was 12 and 8.
Yeah,
so
ours changed last year, and I can't remember what it was, but
I think they're all 12.
were they all 12?
Oh, they all 12, so...
But they're more combined.
Okay, so I think it would be like a very, very quick history, so not like a 6 minutes, it would be like 3-4 minutes, look at some results, and then you have the rest of the time to explain and counsel. So I'd aim between 6 and 8. I doubt they'd give you 12 minutes solidly just to explain.
These ones where it was sort of sole counselling, they were back in the day when it was 10 minutes, I think, or 8 or 10 minutes, when it was just a pure counselling station, whereas now, because they're all 12, I think ours were all like history and counselling, so I think that might be the way they're going now. So this one has come up so many times, it's literally been, like there's probably more years that have had it than haven't. It's something involving a AAA, it's varying sizes, so it depends sort of, the only things that change are what your management is of it and what you advise them, but it's always the same, it's always a history, something to do with urinary symptoms or back pain, and it turns out to be a AAA on a routine scan that they have on an ultrasound scan, and he's found to have AAA, and it just varies in size between the years really. So you have to then counsel him on the diagnosis and then the management, and that obviously varies depending on the size. So it's just sort of, again, getting just a snappy line that you can use to, you know, whack it out, and then you tick the box and then you can move on. So for AAA, we just did that. It was like a widening section of the main blood vessel running from the heart through the abdomen due to weakness within the vessel wall. And, you know, just roll it off. About how it's usually the thickness of a garden hose, but if part of the wall's weak, it can balloon out due to, you know, the high blood pressure running through it. Important to ask about the risk factors in history as soon as you suspect that it might be something to do with this. You know, just whack out the risk factors. So smoking, hypertension, diabetes, cholesterol, men more than women, obviously. High age, if you've got a family history of any sort of vascular disease. And again, just mentioning how common it is to put the patient at ease. So 1 in 25 men over 65 have an aneurysm, whereas only 1 in 10,000 have an aneurysm that ruptures. So, you know, it's not sort of a death sentence. The risks are obviously size dependent, so most are small and don't pose any risk to health, so you can just, you know, give reassurance. 1 in 10,000 people, as I said, have ruptured aneurysms. So the treatment decision is completely based on the risk of the surgery, which is obviously quite risky, versus the risk of rupture.
This was one of the classic questions we wondered about that. One student in years gone by, they described the patient as a ticking time bomb. So obviously, stress the importance of them getting checked out, but don't terrify them and scare them. Just be careful what you say.
This year as well is the first year where the screening programme for AAA is meant to be nationwide. So that might somehow come into the OSCE, as now it's meant to be something that's everywhere. So that's men aged 65 to 74, and they just have an ultrasound scan and then monitoring depending on how big the monitor is. So the treatment decision, as I said, is based on the size of the aneurysm on the scan. So 3 to 4.4, you just get a yearly ultrasound. 4.5 to 5.5, you get a scan in 3 months. And if it's over 5.5, that's when you consider the surgery. There's also other things that come into account. So if you've got a scan, aneurysm between 4.5 and 5.5, so that's sort of on the borderline. If they've got a fast rate of growth, so if on the scan in 3 months it's, you know, grown quite a lot, then that's obviously puts you at high risk, and so then you'd be considered for surgery. Also, if you've got a family history of ruptured aneurysm, that makes you consider for surgery at a lower aneurysm size. And also MMP9, which you can measure, which is something that's in the blood, which is just a measure of vascular wall damage. I don't quite know exactly how it works, but that's also meant to put people at high risk of rupture, so then you'd consider for surgery that 4.5 to 5.5 bracket. Again, as I said, risk versus benefit. So there's 2 ways that you can repair it, the endovascular or the open. As a general rule, sort of, if the patient asks. Like, you don't really need to go into it in too much detail because that's the vascular surgeon's job. But EVAR as a general rule, it's got less risk, but it's got a higher rate of complications, especially longer term complications. So in somebody that's younger, you generally want an open repair because that will last longer. And then, as with all of them, lifestyle always comes into it. So just like mentioning other ways, you know, stuff that you can actually give advice on, because like you can't really give advice on different types of vascular surgery, but you can tell them about controlling the blood pressure, you know, stopping smoking, diet and exercise, having a statin to lower their cholesterol. And that's that. Any questions about that one?
If someone has a screening, but their aorta is a normal size, do you then, like, how often do you then screen them after that?
That's the yearly screen.
Oh.
The yearly ultrasound.
That's what's just coming into place, so there's no nationwide.
Yeah.
So if they've got like a normal size aorta, you still do it yearly?
Yeah, that's that 3 to 4.4 one, is just the yearly ultrasound.
Is that just going to be within a GP context?
Pardon?
Is it going to be within a GP context or within mobile units?
Within what?
The GP. I think they would get.
You can,
At
at the moment,
it depends if the GP has the facilities to do it or if the ultrasound.
yeah, I imagine at the moment it
Ultrasound
would be
would be.
hospital clinics.
Yeah.
At the moment, it's just if you're over 65, you just sort of request it at the moment as a man. But I think by April, it's going to be, you know, letters sent out like cervical screening and stuff. At the moment, it's fine.
Okay. So this is another one that kind of gets phrased differently each year. So I just picked one way you had to take a history from a patient who had gastro symptoms, and then you sort of said to them, go for an OGD and see what's found, and then they give you some results. So they said for this lady, she was H. pylori positive from the tissue sample they took, and she had an erosion in the terminal pyloric antrum, which is likely to be an ulcer. Can you please tell her what's going on? So it seems it's quite straightforward. Like, you'd all be quite happy to do that, I think, if you practiced it like once or so. So again, you need to assess what the patient knows already about why they went for the OGD, because if you don't do that, you just get into a world of trouble. And I always like to just say at this point, have you got any worries? Because then it's an easy way to get that out of the way, and you don't even need to address them at that point. You can stick to your plan. You can just, you know their worries and say, I'll talk to you about that later, and then it's done. So again, you define what the ulcer is and what the results showed and what H. pylori is, and then you just do the same framework. So you discuss risk factors for the development of the ulcer. So middle to late age, the incident does tend to increase with age, and it's more common in males rather than females, more common in patients with blood group A. Might not explain this in the counselling scenario because they're not going to know what you're talking about, just for a side note. And it's high risk in people who smoke, have H. pylori in the stomach, and with high use of NSAIDs. So the patient isn't going to know what NSAIDs are probably, so again, explain that to them in more basic language. And then you do treatment options. So I like to do lifestyle, medications, surgery, or sort of conservative, and just see how it makes sense for you guys to split it up. But they do like you to having a logical pattern to doing it. So lifestyle changes, you know, it makes sense to do after you've done the risk factors for them. So smoking cessation, advice and referral, to reduce stress levels in her life, do a food diary just to see if there's anything that aggravates it, reduce alcohol intake, and reduce the use of NSAIDs, and offer alternatives for that. It all sort of makes sense. And then the medication, you don't need to go into this in so much detail. It's just, you can literally tick off lifestyle changes. So you don't need to sort of talk to them about smoking cessation and how they do that. It's literally, I'll offer you smoking cessation, you need to reduce stress levels, and then it doesn't take very much time, but you're ticking all the boxes, because you don't have very long flies by. And the medications, again, the patients don't want to know exactly what it is. You just need to stress sort of the triple therapy, and that they need to do it for the full course, and what they are. So it's 2 antibiotics, and then something that reduces the stomach acid in as well. And then they might need to be on the PPI for a longer length of time. And then surgery, maybe just mention that it's only very extreme cases, but obviously this wouldn't be the case for her yet. And then, as with everything, you need to talk to them about complications and warning signs. The main one is if she does actually get really severe pain, and that it could be a perforation. So you need to mention that to them, and what she should do if she does get really bad pain and needs to come into hospital. And that there is a very small increased risk of gastric malignancies. Again, don't dwell on this, it's just mention it to them sort of reassure them that it's very small risk, and then mention that. And then just in the future she might need more surveillance, such as another OGD, and once she's had the H. pylori triple therapy, then she might need another test just to make sure she's got rid of it. And they test it now as a stool sample and just test the antigen and that. So it's quite simple and non-invasive. And again, always at the end, summarise, check understanding. Have you got any questions? They're just such easy things to make. So other examples of this scenario were things explain results of colonoscopy, and I think someone had, did they have Crohn's, I think, from colonoscopy. So again, it was just explaining to them what Crohn's was and going through this logical order. Or they actually have done a couple where it's explained what an OGD is or colonoscopy is.
Yeah, there was one where it was a lady and you had to take a history, and it was like weight loss, fatigue, like all those sort of constitutional symptoms basically, and then you got your investigations, which is 9 deficiency anemia, and then you had to counsel her on the fact that she'd need colonoscopy. You had to rule out malignancy.
And for that, if you follow the pattern that you would for consenting someone for a procedure, it just makes it more logical. So you assess their understanding of why they're going, you explain what the procedure involves, you explain risks, explain the benefits of it and why you're actually doing it. Like summarise it, get them to repeat and think back and ask for any questions. And it just makes it really logical if you always have that in your head. Even if you don't have the knowledge necessarily to go with it, you can just rely on knowing that and actually knowing little bits about it. Have you got any questions for ADD? Does that all make sense? Yeah. Okay. Then the last case we're just going to talk about is C. diff, and I think with C. diff and MRSA, it's just so common in the Leeds Trust anyway at the minute. They're going to have, well, they're likely to have a C. diff or an MRSA question on the OSCE because it's so prevalent and it's what you'll be doing as an F1, you'll be dealing with lots of that. So the one we had was take a history, discover the patient has diarrhea, a bit of weight loss, abdominal pain. They're quite young as well, so I think you were a bit confused at first when you're taking the history, and then you discover that they'd had a chest infection or something last week and they'd had a recent course of antibiotics, and then it all clicks in. So it's quite obvious, it does become apparent that it's C. diff, and then they'll stop you and they say you need to cancel the patient on the diagnosis. So again, check understanding, do you have any worries? Probably the patient will have something like, there's cancer that runs in my family and I was really worried that that's what it is. So then you at least know what their worries are straight away and can deal with that later on. And so the diagnosis is just really, really simple language, just common type of bacteria that causes the infection of your colon, leading to symptoms such as you've had. A lot of the population have it, and it does no harm unless there's other risk factors. And that, you need to tell them how it's spread. So feces passed on by person-to-person contact, and it's diagnosed sort of by the symptoms and then by a stool sample. So some of the risk factors, just so they understand why they've got it. So the antibiotics, it disrupts the normal bacteria in the bowel. If you've had previous C. diff infection, you're a lot more likely to have it again. And it generally causes harm in people who are unwell, crowded living spaces and poor hand hygiene. So that's why it's very common in nursing homes or in hospital patients, because it's just such close quarters and obviously people are sick, so it affects them a lot more.
These are quite classic as well for angry relative sort of scenarios. So it's worth just thinking about how you'd pacify someone, all the things that not your fault, but how you'd pacify an angry relative who says that you're killing them with your hospital infection sort of thing, which is another one that seems to pop up quite a bit with MRSA.
Yeah, it's trying to make them understand, rather than blame what's gone on, it's trying to make them understand. So again, you need to talk about complications, and it's easier if you do it sort of common, rare, and that tends to be sort of common, and then the dangerous ones. So the common, they can get dehydrated, and that can affect your kidneys. So what they need to do, they get dehydrated because they're having lots of diarrhea. So it's quite easy for the patient to understand. So they need to replace lots of fluid. Rare, you can get bowel perforation. They're not going to know what that means. So just explain it in simple terms. Hole in your large intestine, which can cause the contents of your bowel to spill out. And then very rare, you can get the toxic megacolon when your colon becomes really distended and it can't get any of the gas or stool out. And if left untreated, it can rupture and it can be really, really serious. But again, you need to mention these things without scaring the patient. So just reassure that these are really, really rare, and that you've sort of caught the C. diff when you have, and that you'll be monitoring them and seeing how they get on.
And a lot of them, like, it's only when people, patients are there and they're like, am I going to die? The simulated patient sort of thing. And it's just like having a way to sort of bounce that question off and just thinking about all the possible things that you can, bounce it off concisely and get rid of it and move on.
Okay, and then you obviously need to know the treatment and management of it. So if he was still on the course of antibiotics for his chest infection, if it's possible and he's better, then you would need to stop it. And because the most common thing is dehydration, they need to be hydrated. So it's, if they're in a GP setting, and they're well, then it might just be encouraging more intake and seeing how they get on. Or if they're in hospital and they're more unwell and having lots of diarrhea, they might need IV fluids, and that makes sense. And then you need to explain to them that the treatment for it is another type of antibiotics, another type that made him unwell and have this in the first place, because that will confuse the patient. So it's a different type of antibiotic that treats the C. diff. So if they're mild to moderate, then you give them metronidazole oral, and if it's severe, then you give them vancomycin. And this is the only time you would use oral vancomycin, otherwise it would always be IV. But because you want it to work in the gastric system, that's why you give it oral. And then they might need surgery if they do become very unwell. But like you say, you've sort of caught it early and you're monitoring them. And then just a bit of education about the use of antibiotics to prevent it in the future. Always finish courses, and if they notice symptoms like this, then just sort of seek help straight away. In about a quarter of patients, I think it is, C. diff does reoccur. So there's not that much you can do to prevent it reoccurring. It's just so they know the symptoms again and know what to do if they do get it. And then just summarise, check understanding, and ice. Lots of ice. They love ice and leads. So have you got any questions?
Is there any there's like a big list, is there any that anyone has any particular, that you've seen, that you have any particular questions about? Or?
I was wondering how much prompting they would give you in the OSCE if you're getting carried away with one of the sections and not leaving the others.
It's
so they're
really
going to stop you and actually move on.
It's really like examiner dependent. Some of our examiners really like pushed you through it, and some of them, like some people's examiners would stop you and say, no, go, no, stop there, like you've got the marks, go, like sort of thing. Whereas some people had examiners that let you monologue about, on and on for the first section, and then that was it. I think a lot of it I think if you come across quite slick, if you've got like a good slick opening gamble, then I think they're a bit kinder to you almost. Like, I think if you start rambling and if you're someone who's just got a little bit carried away, I think sometimes people don't take quite as kindly to you.
I think in these type of ones as well, the key is once you've got their diagnosis and the history, you don't need to ask anything else. It's not one of the histories where you need to ask everything, the social background, everything. It's
as long as
the focus history. Once you find out what it is, they probably will stop you.
And as long as you rattle through the risk factors, that's most of the time these stations are all about the risk factors. So if you've got those in history, then just...
I think one of the ones where I ran out of time was when we're like practicing and things, and you sort of go through the risk factors individually with the patient and say, do you smoke? Oh yes you do. How much do you smoke? Okay, you need to stop that. Whereas you kind of need to get more bullet point desk with them, sort of, if you smoke you need to stop, if you drink you need to cut it down.
I think that's the key to because they are such easy marks. If you just for each one, just don't neglect them and just think about them and just have like a set list of bullet points that you can sort of rattle through, and then they're really easy to pick up marks in.
If you made a choice from there of the history and you're not getting to the diagnosis for some reason, it's obviously going to mess up the counselling for the second bit. Do they?
No, I think they
generally
do tell you. They give you the results normally. So if you've gone down the complete wrong track, the results might not make that much sense to you.
Like there were a few people in that C. diff one that, because he had weight loss, change in bowel habit, I think he had like
family history of
something.
cancer.
He had like a family history of cancer. So a lot of people went down that route, which they still got most. I imagine, well, I don't know obviously, but I imagine they still got most of the marks because you still had to rule out cancer. But as soon as you got the investigations, it was like C. diff positive. So oh right, Okay. So like most of the time, well, all the ones that we've seen and a lot of ones on Dr. Clark, they're sort of like the investigations are such like obvious things like a microcytic anemia or like a C. diff positive that you can't really miss it.
And that's why it is good to practice with your friends with these ones and have your friends be harsh. But if you're running over time, not to just say stop, you need to stop right there. You need to kind of develop a way that you can stop yourself. So if you're practicing with friends and it's really hard once you're like doing a history and you realise you're running over time to end well, the more you practice it, the easier it gets, and you can just have, right, I'm going to stop there, you know, like let's see your results, and you know, even if you lose some points for not being that slick, at least you've moved on. And it's just about not being embarrassed if you do that. They know time's short. You would never take a history and counsel someone for something like this in 12 minutes. That's just ridiculous, and they know that. So, you know, it's fairly forced situations. They're nice stations. Counselling and explaining, they're nice.